Hey everyone, in this lesson we're going to talk about hemophilia A and hemophilia B, and we're also going to talk about the differences between the two conditions. Hemophilia A is a hereditary disorder of secondary hemostasis due to factor VIII deficiency. And this leads to the inability to form fibrin clots adequately. We're going to show the coagulation cascade and how both the hemophilias can alter fibrin clot formation. Hemophilia A is an X-linked recessive condition, which means that males are predominantly affected, and approximately 1 in 5,000 males have hemophilia A. Hemophilia A is on a spectrum of severity. There are mild, moderate, and severe forms of the condition. And with disorders of secondary hemostasis, like hemophilia A and hemophilia B, the presentation often involves delayed bleeding. So if there's a cut or there is a surgery with an incision, there is not a quick bleed, but there's often a delayed process of bleeding. Other presentations include deep bleeds, so deeper structures are more likely to have bleeds, and this can often present as spontaneous hemarthroses or blood within a joint space. If you see blood within a joint space for any reason, think about the hemophilias. Oftentimes, these individuals can get hemarthroses simply just with walking with severe forms. Lab investigations generally demonstrate a decreased expression of factor VIII as well as an increased PTT. However, the PT and INR are normal. Treatment involves using desmopressin or DDAVP for mild forms of hemophilia A. DDAVP is an analog of arginine vasopressin. And for more severe conditions, we can use factor VIII concentrate and tranexamic acid prophylactically. Hemophilia B is also a hereditary disorder of secondary hemostasis, but this time it's due to a factor IX deficiency. So this makes it easy to remember. Hemophilia A is due to a factor VIII deficiency. Hemophilia B is due to a factor IX deficiency. A comes before B, VIII comes before IX. Hemophilia B is also an X-linked recessive condition, which means it is a male predominant condition. Approximately 1 in 30,000 males have hemophilia B, and half of the males with this condition have a severe disease form. Like hemophilia A, hemophilia B presents with delayed bleeding, deep bleeds, and spontaneous hemarthroses. Lab investigations show a decreased activity of factor IX and an increased PTT, but INR and PT are otherwise normal. Treatment of hemophilia B involves factor IX concentrate and tranexamic acid. So here is the coagulation cascade. We're going to quickly go over the coagulation cascade, but if you want more information on the coagulation cascade, please check out my coagulation cascade lesson. Activated factor VII, which is denoted with a little a, and tissue factor work together to activate factor X to activated factor X. And I want to just mention that activation of these factors involves proteolytic cleavage of the precursor. So when we have activated factor X will proteolytically cleave small amounts of prothrombin to small amounts of thrombin. Once we have thrombin, thrombin has a wide variety of downstream effects. It will activate factors 13, 11, 8, and 5. So a lot of different downstream effects, and I'm going over them very quickly. So when we have an activated factor 11 proteolytically cleaves factor IX to activated factor IX. And thrombin is already acting on factor VIII to form activated factor VIII, and these factors combine to work on factor X again, proteolytically cleaving even more factor X to activated factor X. With the activated factor V, activated factor X proteolytically cleaves large amounts of prothrombin to thrombin. Thrombin will then act on fibrinogen to produce fibrin, and factor 13 will take that soluble fibrin to make it insoluble fibrin. But what I want you to really focus on is factor 8 and factor 9. Factor 8 deficiency, again, is hemophilia A, and factor 9 deficiency is hemophilia B. So you can imagine if you have low levels and low activities of these factors, we're not going to get proper fibrin clot formation because we're not getting activations of large amounts of thrombin. So that's the reason why we get an inadequate formation of fibrin clots. We get platelet plugs, but we don't quite get an adequate functioning of secondary hemostasis simply because of deficiency in these two factors. So in summary, what are some of the similarities and differences between hemophilia A and hemophilia B? Hemophilia A and B share certain characteristics in common. They are both heritable. They are both X-linked recessive, which means that they're both male predominant. And they both have an increased PTT. And they're also both disorders of secondary hemostasis. So that means that they all have the same presentation: delayed bleeding, deep bleeds, spontaneous hemarthroses. However, where they differ is that hemophilia A is due to a factor 8 deficiency. It's a more common condition as well, so it occurs in about 1 in 5,000 males. And it can be treated with desmopressin for mild forms of hemophilia A, factor 8, and tranexamic acid. Hemophilia B is due to a factor 9 deficiency. It is a more rare condition, so it affects about 1 in 30,000 males. And you use factor 9 for treatment and tranexamic acid as well. Guys, I hope you found this lesson helpful. This is a lesson on hemophilia A and hemophilia B. If you did, please like and subscribe for more lessons like this one. Also, check out my other hematology lessons. Thank you so much for watching, and I hope to see you next time.